So we're going to go ahead and get started here with a little case study. And we're going to be talking about the riddles of the rebellion. And our speaker this morning is one of our infection preventionists from the HAI program. And we have Beth Ellinger with us this morning, who is going to be giving this case study for us. So welcome, Beth.
Thank you. Okay, can you guys hear me okay? All right. Okay, so Riddles of the Rebellion. This is a case study that involved a lot of lab partners. So Anna Marciniak is one of our IPs who gave one of the talks, I think, in Eau Claire. And then Rebecca LeMay, also one of my colleagues, gave the presentation, I believe, in Fond du Lac. So here's me. And then disclaimers. So the HAI program is non-regulatory. We're part of the government. We're here to help. There's no affiliation with any facilities or products, and all of the content and guidance that we provide is based on CDC guidance and best practice in infection prevention. All right, so I have to pull my notes out because I'm not super familiar with Star Wars like a lot of other folks. So here we go. All right, do you guys know what this droid is? Megan, I'm surprised. Okay, well, I didn't know either, but this droid is a FX7. It's an antique medical droid that specializes in the diagnosis and treatment of injury and disease. It serves the Rebels. Multi-armed FX7 assisted the emergency medical facility on the planet Hoth, or Hoth, I don't know. I believe it's Hoth. So infection preventionists and other clinicians rely heavily on diagnosis and test results to help that occur in the lab. And so knowing these test results, IPs can provide safe interventions. We can help medical personnel and also to prevent any exposures. So in our case study today, we're going to discuss some key partnerships that occurred during the identification and treatment of a rare infection. And this is something that maybe FX7 might diagnose. Okay, so here's our agenda for today. We're going to review the case study. We're going to do some pathogen background and Wisconsin update, and then highlight clinical laboratory partnerships. All right, so let's dive in. And now I have to refer to my notes because I'm not huge into Star Wars. Here's a picture of a loth cat from Star Wars. So they have sharp teeth and claws, like all cats. And these cats are cute, but they're also, and friendly, but they can also be temperamental, just like real cats. Sorry, Lynn. So getting into our case, on October 7th, our patient was bitten or scratched by a stray kitten. I'm not sure of the background, but I believe that they found this kitten on their property. So this person wasn't sure if the injury was from a bite or a scratch. They took the kitten to the Humane Society because it was sick. It had respiratory symptoms and dehydration. So then our patient, a week later, on 10/14, went to their doctor, and they were started on a Z-Pak and Augmentin. Their clinical presentation was thumb pain, fever, swollen lymph node of the right axilla. Then on 10/16, the patient presented to the ED for increased pain and swelling again. And at that point, the patient was admitted to the hospital and started on Zosyn IV, which was then switched to Unison. So the initial culture was collected from a walk-in clinic, was sent to the Wisconsin State Lab of Hygiene for further identification. And the state public health veterinarian, based on the patient's account, was updated by the local health department. And then of note, on 10/17, the kitten died at the Humane Society and a necropsy was done. It was inconclusive for any specific pathogens, and no specimens were collected at that point. So we don't know if any PPE was worn during that case of the necropsy. So depending on the pathogen, there may be some possible laboratory staff exposures and Humane Society staff exposures. So we have a few suspects, some of our Ella organisms. So any thoughts on what this could be? This is not a clicker question. Pasteurella, that's pretty common in an animal bite. Could be that. Bartonella is catch scratch fever, so it maybe could be that as well. Legionella, not likely. This wasn't a water source type of exposure. Bordetella, not likely at all. Whooping cough is going around, but probably wasn't the cause of that wound. Francisella, possibly Francisella tularemia is correct. So, just so you're aware, tularemia was not identified in Tatooine. But the fun fact is tularemia comes from Tulare County, California, where it was first identified. So here's a lab results for the PCR for DNA and culture. They were reported positive for tularemia. So we're going to take a pause from the case study and just do a little background on tularemia. And here we go. So tularemia is a very small gram coccobacillus. It grows better on chocolate agar than on blood, and it's a very slow grower. And just for awareness, these pictures were from the Wisconsin State Lab of Hygiene. Also, tularemia is a very highly virulent organism. It has a low infectious dose. You only need about 10 to 50 organisms, and it has a wide host range. There are about 125 cases a year within the United States. And most patients have a history of animal contact when they are positive or diagnosed with tularemia. So here's our modes of transmission. We have arthropod bites, handling infected animal tissue, bite from an infected animal, ingested contaminated meat, water, or soil, agricultural dust, laboratory exposures, and mowing over rabbit nests, which seems really unfortunate. So here's a clinical presentation in humans. And per the CDC, the symptoms usually appear 3 to 5 days after the exposure, but the range is from 1 to 14 days. And it's a febrile illness that includes chills, headache, myalgia, fatigue, sore throat, cough, shortness of breath, vomiting, and diarrhea. And prominent lymphadenopathy is typical as well. And so the clinical presentation of tularemia is variable, and it really depends on the route of the inoculation, the dose, and the virulence of that organism. So here is just some information on our cases. Between 2000 and 2023, we've had about 27 cases over the past 24 years. And here's a little bit more about our tularemia cases, just some descriptive epidemiology. And you might be wondering what's going on in La Crosse. And this is from one of our infectious disease epidemiologists. I don't know, you probably know her, Rachel Close. She says presumably there's something going on in that environment in that part of the state that's just conducive to tularemia life cycle. There's not really a good explanation, but really seems like that's probably the most likely. And you might be curious about other areas of the United States. Tularemia has been reported from all the states except Hawaii, but most common is South Central United States and the Pacific Northwest. So diagnosis, confirmatory diagnosis for tularemia is culture or serology. Then there's other presumptive diagnostic options, PCR, direct fluorescent antibody, and immunohistochemical staining. Okay. So back to our case study. If you remember, at this point, the patient was an inpatient at the hospital. So our team was contacted because the hospital IP reached out to our regional infection preventionist for that area. They wanted to double check on recommendations for PPE and transmission-based precautions. So in line with CDC, obviously we're gonna recommend standard precautions, but then there's also not super great evidence, but in infection prevention, we always default to the highest level of protection. So healthcare workers could be exposed when they're doing some type of wound debridement. So what was recommended was, if that was something that was necessary for that patient's care, they would want to be in a negative pressure room and use respiratory protection, so fit-tested N95s, because if there was any aerosol generating that was performed during that wound debridement. But again, this is something that's not really well defined. So the hospital intervention was wound debridement was necessary. The staff was obviously concerned, which is why that IP reached out. So on 10/18, that patient had their wound debridement because it was, clinically needed. So at this point, the local health department is involved, the clinical lab's involved, the state health department and the epi section, and us in the HAI program are all involved in this case. So here is a picture of our poor patient's wound. Not sure how familiar you are with wound care, but this wound was packed with a dressing, and this dressing helps stimulate granulation tissue for wound healing. And there's a wick that sticks out of the dressing to kind of wick away any liquid, but also as this wound heals, it'll start pushing that wick out, and eventually that wick would be removed. So they were waiting on the tularemia results, but they had kind of their suspicions up. So then on the 19th, that was a day after the wound debridement, they got the positive results. So CDC has a really nice fact sheet that we shared with the facility, especially the employee health department, what needs to be done. Definitely checking on our friends in the lab. They would definitely be exposed. What is generally best practice would be post-exposure prophylaxis and symptom monitoring for 14 days after that exposure. So there was a meeting of the minds with the state public health veterinarian, some others at DHS, our friends at the state lab, the local health department, and the hospital infection prevention and ID and the laboratory. And so this really was a great example of everyone pulling together and finding a solution to any exposures. So for the Humane Society staff that cared for the kitten and were involved in the necropsy, prescriptions were ordered for them by their local health department. And so that was, I believe, what we have here, 3, so it was less than 10 staff that were exposed at that facility. So for laboratory exposures for tularensis, there's really no set criteria, so it's really important to do a risk assessment. Also important to phone a friend, so contacting the local health department, working with your lab. What is most often the guidance is a fever watch for anyone with a potential exposure, and then possibly fever watch with antimicrobial prophylaxis. So this is a WCLN assessment tool. Each laboratory really should review this in their lab when they have a possible select agent or an exposure. It really helps to recreate that lab flow from the specimen to the folks in the micro lab. And I believe Erin's gonna talk about this in one of her presentations, so that's all I'll say about that, but very helpful tool. So conclusion, there were no further transmission. None of the exposed staff at the Humane Society developed symptoms. Laboratory staff remained asymptomatic. Also no exposures from the healthcare workers that cared for that patient. But it starts with the clinical lab, but here are all the people that are pulled in based on the work that you guys at the clinical lab do. The state lab, local tribal health departments, our state public health vet, that's a typo, but it should say infectious disease epidemiologist, the hospital or clinic IP, any ID physicians, the clinical team, and the Humane Society staff. So a lot of people came together to review of this case. So here's a shameless plug for our program. We really act as a liaison for the Bureau of Communicable Diseases with the State Health Department, CDC, and other agents. We help with risk assessments, so with occupational health, clinical labs, and with clinical staff. Our goal is really to ensure the safety of laboratory folks and clinical staff by proper use of PPE and post-exposure review. And then we can also help with facilitating conference calls and other means of sharing information, providing a place for everyone to ask questions and discuss the situation. So in conclusion, clinical labs are vital public health partners for surveillance and prevention of infectious diseases within the communities they serve. And obviously collaboration, teamwork makes the dream work. So thank you for that. And questions, I can take questions. And then this is our main HAI inbox here at the state, main phone number, and then our website too, if you need contacts with regional IP or other folks. So I can take questions if you have any.
Any questions for Beth? All right.
Thank you.
Beth, so much. Great job.